Hey everyone. We've talked about this a few times in class already, but this chapter is going to talk about pay for performance and value-based purchasing, which those are those payment systems that reward doctors and hospitals for treating patients with higher quality of care for a lower cost, also known as efficiency. So this was part of that transition from getting paid per patient, so trying to see as many patients as possible, to being paid for what quality the patient received, what are the patient's outcomes, and were they satisfied with their care. Okay. A lot of times these terms are used interchangeably because they are very similar, but they have slightly different definitions. So pay for performance is any type of provider's payment system that is based on performance and incentives, okay, money. While value-based purchasing is when the purchasers like Medicaid hold the providers accountable for both the cost and the quality of healthcare. Okay, very similar, just that slight difference. They both have the same goals, though, to improve the quality of care, to reward the provision of quality care, and to control costs directly. So these are different from the traditional fee-for-service payment system, right, where they're getting paid for each particular service that's provided. With pay for performance and value-based, the doctors are having to do a little more to meet those quality standards than just provide the service if they want to get that full payment. Okay. Like I've mentioned before, the Department of Health and Human Services, DHHS, and CMS have been implementing these types of payments in the Medicare program for a while now to shift payments away from how many patients a doctor can see to how well and how efficiently they're seeing patients. Medicaid is also making the shift to value-based payments under Medicaid managed care programs. So this began in 2015 when the Medicare Access and CHIP Reauthorization Act, or MACRA, repealed the formula that was being used to pay doctors and changed it to be like the Medicare ones. So to give you an idea, in 2017, almost 50% of insurers' reimbursements were now value-based. Okay, so there's been this big shift, like I mentioned. With MACRA, CMS wanted to not only incentivize doctors with money to provide this efficient care, they also wanted to reduce payments for doctors that were not meeting the performance standards. So to do this, the Quality Payment Program, or QPP, was created. So it's meant to help doctors focus on caring for their patients rather than filling out paperwork. All right, so it's supposed to help out the providers. Under the QPP, Medicare doctors, PAs, and nurses have to participate in one of 3 tracks to get a positive, neutral, or negative Medicare payment adjustment in subsequent years, so in the upcoming years. Doctors have 3 tracks to choose from based on their practice size, specialty, location, or patient population. Okay, so the 3 tracks are Merit-Based Incentive Payment System, MIPS, Advanced Alternative Payment Models, APM, or MIPS Value Pathways, MPS. So we're going to go through each of these next. The first one is MIPS. This is for Medicare Part B services, and doctors get rewarded for improving the quality of patient care and outcomes. There's 4 performance categories that this one looks at. Quality measures the quality of care based on measures of performance. Promoting interoperability looks to see if patients are being encouraged to engage by using patient portals like MyChart and things like that. This category is also looking at the use of electronic health records for the exchange of information. The next one is the improvement activities category, which assesses participation in activities that improve clinical practice and support patient engagement. And the cost category assesses the cost of the care on Part B claims. In order to meet the requirements for the quality payment program, doctors have to successfully report on 6 clinical measures over a 12-month period. Depending on how they measure, doctors will get a score for each category that will combine to give them their overall MIPS score. And depending on that score, they're either going to get a bonus payment or a penalty. Each doctor can choose from 200 quality measures and more than 100 improvement activities to report on. So they get to pick like which areas they want to look at. And then each July, CMS will let them know what their MIPS score from the year before was, and so how their payment's going to be adjusted for the following year. When MIPS was first implemented, it was pretty easy to get a bonus, but over the years, it's gotten harder to get to that bonus threshold. When a doctor doesn't meet the threshold, they have to pay into what's called a penalty pool. So the money that's in the penalty pool is what pays for the MIPS bonus payments to the doctors that do meet the threshold. So the doctors that are not meeting it are paying the doctors that are meeting it, basically. Okay, moving on to the second track. Advanced alternative payment models are risk-based arrangements between doctors and payers. So between doctors and CMS or doctors and the private payer, okay? In order to satisfy the requirements of the quality payment program in this track, doctors have to prove that they bear a certain amount of financial risk and that they're using a certified electronic health record, okay? This track is designed to make it easier on doctors to report these things in the hopes that more doctors will participate because it's easier. Also, the base payments on quality measures are comparable to those in the MIPS category, but APMs kind of create some new ways or alternate ways for doctors to get a higher score. Okay, MIPS value pathways, this is the third track, is the newest pay for performance program. It began in 2021. MVPSs are subsets of measures and activities that can be used to meet the MIPS reporting requirements. So the goal of this one, the MVPS, is to promote interoperability and so that doctors can pick measures that are relevant to their specialty. So what it means there, where it says, to move away from siloed reporting on the slide, if you think of a silo, it's like a big standalone structure. So that's how it was being done before. This specialty can meet this set of measures. This other specialty has a separate set of measures. But MVPS made it to where the measures are all aligned and connected, but still allow for specialties, if that makes sense. Okay, so I just said interoperability, but what is that? It is defined as the ability of different information technology systems and software applications to communicate, exchange data, and use the information that has been exchanged. So, like a big goal with interoperability was for when a patient is being treated at different facilities. So, say a patient with cancer that's being seen here at Women's Hospital, but is also being treated at MD Anderson in Texas. The patient would either have to request and bring her medical records with her back and forth each time she's seen at each facility, or the hospitals would have to request her records every time she's seen at the other facility, right? Interoperability makes it to where these two completely separate hospitals can share or exchange data, the patient's health record, seamlessly. So she can be seen here at Woman's, and the next time she goes to MD Anderson, the doctor has already seen her records and been able to review them beforehand, so he can just continue care. Okay. And I know this seems like, yeah, of course we should be doing this. Why hasn't it always been done like this? That's because it's a lot easier said than done. There are a lot of challenges with interoperability. The Continuity of Care Document, or CCD, was created for when, let's use the same example. Say when Woman's Hospital is using one document format and MD Anderson is using a different one. They can't pull each other's records into their own systems. They would have to either manually enter everything in, or really what they would do is scan the documents in. The CCD uses a standard format to share the patient's information, like a universal format. So in your EHR, like your hospital's EHR system, you can export a CCD that the other hospital's EHR system can import into theirs. Okay, hope that makes sense. Another challenge with interoperability is that a lot of facilities use vendors for their EHR systems, meaning it's these companies that are kind of running their EHR system, for lack of a better term. So each vendor company has their own protocols for information transmission. So just making sure everything with interoperability is meeting the vendor standards. Also, some facilities have older hardware and software, so their computers or software may not be able to work with this new technology for interoperability. So that's a big expense on the hospital. Okay. CMS also created the Hospital Value-Based Purchase Program in 2010 through the Accountable Care Act. They also created the ones you see listed here: the Hospital Readmission Reduction Program, the Hospital Acquired Condition Reduction Program, which should sound very familiar. We talked about that one last chapter. The End-Stage Renal Disease Quality Initiative Program, the Skilled Nursing Facility Value-Based Program, and the Home Health Value-Based Program. So let's talk about each of those. First up is the Hospital Value-Based Purchasing Program, or VBP. The Social Security Act set the statutory requirements for this, meaning the legal requirements. This program rewards acute care hospitals, so like a Baton Rouge General, with incentive payments for quality of care in the inpatient setting. So that means these payments are adjusted from the inpatient prospective payment system, right? The IPPS payments for acute care hospitals. These programs rely on the hospital to report on these measures accurately, first and foremost, but also in a timely manner, okay? The VBP uses these quality domains: clinical outcomes, so what were the patient's results after treatment, person and community engagement, so this is involving patients in their own care. Safety includes like the steps taken to prevent hospital-acquired conditions. And then efficiency and cost reduction, that's giving high-quality care at a lower cost. Okay, these performance measures are quantitative tools, meaning it's something that can be actually measured to show quality. They have to be reliable, meaning they're consistent over time. And they have to be valid, meaning they're clinically relevant and scientifically sound. So these are proven ways to show quality, okay? It's not just someone like, yeah, I think we're doing a good job. No, they're actually measuring things. And again, the facility gets to choose which measures they're going to report on. So they should choose things that they're doing well, right? That's going to highlight the quality of their program. The measures are split into 3 categories: structure, process, and outcome. So an example of structure-based measure would be the facility having health information technology and using an EHR. For the process category, that's referring to the facility using evidence-based processes. Okay, so this would be like prescribing appropriate medications that are like evidence-based to work. And then outcomes is showing what is the outcome for the patient after being treated at your facility. So an example of that, an outcome measure, would be like mortality rates. Okay. All right. The next program is the Hospital Readmission Reduction Program, or HRRP. The goal of this program is for hospitals to improve communications and care coordination so that patients and caregivers are more part of the process, especially in discharge planning, with the hopes of reducing the number of readmissions. Okay. Readmissions are bad for hospitals. It's not good if your patient has to be readmitted after being discharged, because that means you didn't get them to a point where they could be fine at home or wherever they were discharged to. So that looks bad on the hospital. A readmission is defined as any unplanned readmission that happens within 30 days of discharge from the initial admission. And it can be an admission to the same hospital or a different acute care hospital. So CMS looks at these readmission numbers. They use an excess readmission ratio, or ERR, which measures a ratio of predicted to expected readmission rates. So what does that mean? The predicted readmission rate is what they predict or think the 30-day readmission rate will be based on the hospital's case mix, whereas the expected readmission rate is how many readmits they expect in that 30-day period based on the readmission rates at a different hospital that has a similar case mix. Okay. So the excess readmission ratio, the ERR, is a measure of the hospital's relative performance. Okay. Next is the Hospital Acquired Condition Reduction Program. Again, we've talked about this one a bit. The program incentivizes hospitals to use best practices to cut down on the number of hospital-acquired conditions. So those problems that can totally be prevented that happen to a patient while they're admitted, like a fall or an infection, okay? CMS reduces the hospital's payments if they're not doing this well. And they base the hospital's score on 6 quality measures. So 1 composite measure of patient safety and adverse events. Adverse events are like things that are not supposed to happen. And the other 5 are chart abstracted measures, so pulled from the patient charts of healthcare associated infections. So when there is one of these preventable infections, like an infection of a surgical site, so this gets reported to the CDC's National Healthcare Safety Network. So the other 5 measures are taken from those incidences that get reported. Okay, the Skilled Nursing Facility Value-Based Purchasing Program, or SNF VBP, incentivizes skilled nursing facilities to improve quality of care with, you guessed it, higher payments. Okay, this is not an optional program. All SNFs that get paid under the Medicare SNF PPS have to participate in this. So this program uses the SNF 30-day all-cause readmission measure. So it looks at any unplanned readmissions within 30 days of discharge, okay? The Hospital Inpatient Quality Reporting or IQR program was mandated by the Medicare Prescription Drug Improvement and Modernization Act of 2003. And it lets CMS pay hospitals more if they're reporting on these quality measures like they're supposed to. So for this, CMS pulls data from hospitals that are paid under the IPPS, and the goal is for more transparency, so patients can make more informed decisions when they're choosing a hospital. And that in turn makes hospitals really want to improve quality, right? Because they know patients aren't going to choose them if they have a lower quality rating than the hospital down the street, right? Then on the flip side of that, we have the Outpatient Quality Reporting Program, or OQR. So very similar to the inpatient one, but this was mandated by the Tax Relief and Healthcare Act of 2006. And hospitals have to meet all the requirements or they get a 2% reduction in payment. So they're not incentivized with more money for this one. They'll get some of their payment taken from them. In the hospital OQR, CMS is going to look at, like, for example, every patient with a specific diagnosis and see if the doctor uses the treatment plan that's known to be most effective versus using a different treatment plan. There are exceptions to this, like sometimes a patient will have a chronic condition that makes the most effective treatment plan actually not the best for them. But for most cases, doctors should use, that best practice plan. Okay, the next program is the End-Stage Renal Disease Quality Incentive Program. This one is to promote high-quality services in renal dialysis facilities. Payments are reduced if the facility doesn't meet the performance standards, which fall into these 4 domains: clinical care measures, care coordination measures, safety measures, and patient and family engagement measures. Okay, and the last program is the Home Health Value-Based Purchasing Program, HHVBP. This one was implemented in 2016 by CMS to see if having these payment incentives for quality care would actually help improve the quality of care. Is it actually working, these incentives? And this one's just specific to home health services for Medicare patients. And based on how the first few years have gone, it actually has improved the quality of care without adding too much burden on the doctors. So they've found that there's been an improvement in the functional status for home health patients, and the number of unplanned hospitalizations has gone down as well, which is great. Okay, so if I could summarize what all of these value-based purchasing and pay-for-performance programs do in one sentence, it would be that they're using either an increase or decrease in payments to incentivize better quality of care, right? They all just have a few differences. So healthcare facilities, whether they like it or not, want to do well in these programs so that they can get all of their money. One way that they prepare for these programs is to use performance indicators. Key performance indicators, or KPIs, are well defined, okay, so very specific things for the hospital to look at and analyze to make sure they're doing the best they can and to increase satisfaction for both patients and providers, right? They don't want this to be a huge burden on doctors either. That, their doctors are what are making them money, are all the providers, not just doctors, nurses, PAs, all of that. So they want to make patients and providers happy. A lot of times hospitals use these metrics to compare themselves to other hospitals in the area, right, to see how they're doing. Okay. KPIs were developed by the Healthcare Financial Management Association. So they did a bunch of research and figured out these key areas in the revenue cycle that need to be looked at. types of denials, scheduling, registration and pre-registration areas, health information, and the charge master. Okay, so the hospital uses this tool that the Healthcare Financial Management Association created to track their performance using these industry standard metrics, which is called and it makes these map keys. So each map key measures like a specific revenue cycle function. And then this information is made available to the public in the form of these map keys, okay? So then hospitals can compare themselves to their peers. You and I can check it out too. So some of the financial KPIs for hospitals are average treatment costs. So this is not for the patient. This is how much the hospital is spending to treat each patient. Insurance claim processing time and cost. So if insurance claims are processed faster and with a higher success rate, then patients will usually incur less costs and then they're happier. So they're more likely to use that hospital again and even recommend it to people. The clean claims ratio. So this shows the percent of claims that have no errors and that only had to be filed once. Claims denial rate, it kind of goes along with the previous two. AR turnover. Remember, AR is the accounts receivable. So a high AR turnover shows that payments are being collected in a good amount of time. So that's good. Whereas a low AR turnover is bad. That means they're having trouble collecting payments. And then the total and operating margin is the balance between expense and revenue. So this shows if the hospital is making a profit, neutral, or operating at a loss, like losing money. But you can use KPIs for any department, not just the revenue cycle departments. So like the nursing department would want to see metrics on medication errors and things like that. Okay, these are just the financial ones. All right, and I believe that's it. Yes, so good luck this week. Let me know if y'all have any questions, and I'll see y'all next time.